Good afternoon, everyone, and thank you for joining us for another rendition of the Transplant Institute lecture series. And it's a pleasure today to have with us Dr. Joe Scalia, who comes to us from the American University of South Carolina, a remarkable program that has been met with great success more recently because of people like him joining the team there. And Dr. Scalia, for many people who do not know him, is the classic surgical Imagineer. This is a person who walks in a room and can tell you how to innovate to change either the room design or the weather in your city or the delivery of your organs or even how to better manage your patients. And this is what's so exciting about him being here, because transplantation, as you all have experienced, is going through rapid change in the last few years. And we always say this is the most exciting time to be in transplant, whether it's because of medications, devices, or location opportunities, and xenotransplant, and so on and so forth. All these will pose challenges, and with those challenges reside a lot of opportunities. And Dr. Scalia is one of those people who can pin out those opportunities and start a company on his own. Currently, he's a professor of surgeon immunology, tenure track at MUSC, and vice chair of surgery for entrepreneurship. And he's director of strategic operations and innovations at the MUSC Transplant Center, and executive medical director of a venture company at MUSC Health Solutions, and that is heavily funded through the enterprise. His training was he's a native of Maryland and grew up there and went to school in Maryland and went on to do postdoc research in transplant biology with Dr. Sachs at Mass General. And then subsequently did this fellowship at the University of Wisconsin, and then gravitated back to MUSC after working for a long time at the University of Maryland, a very, very busy center where they do most of the work, and Hopkins gets the credit for visibility. And in his free time, as being an inquisitive person, he pursued an MBA at MIT. And this is, I call it, in his free time among the busy jobs that he has. Now, currently, he's managed the nation's busiest kidney program. It's hitting 600?
Well, yeah, we're towards 600.
Towards 600 this year, earning awards for outcomes, quality, and innovations. And he directs a $150 million city initiative to scale MUSC to over 1,000 transplants annually. And accordingly, he serves as the director of the strategic operations for the Transplant Center. And he additionally manages that 30 million fund for MUSC as a venture capital as well. Now, on the innovation side, Dr. Scalia pioneered organ delivery by drone that led to starting the company called MediGo, with starting the first process with over 100-person team that performed the world's first transplant delivered by drone in 2019. And it was written up in multiple editorial venues. The NIH-funded work led, like I said, with the formation of MediGo that got acquired in a publicly traded company. And his most recent innovations include the AI-driven organ acceptance automated post-transplant management. And this is on the side of doing a transplant-related research biology and owning multiple patents there. And to top it all off, he's a humanitarian. For those people who have not had the chance to look at his TEDx talk, 4 Reasons to Live. And I will not, from a transplant patient perspective, I will not tell you what are the 4 reasons, but it's not going to work every day. So I urge you to all listen to that. And with this, I welcome Dr. Joe Scalia to talk to us about beyond your 4 walls, innovating our way to the next decade. And please silence your phones, otherwise you'll hear from Sue. So thank you.
Thank you guys for the opportunity to come here. You know, Marwan and I have been friends for a long time, and my wife was saying last night, you know, how do you know Marwan? We've never worked directly together, but in transplant, as Dr. Nasser and I were just discussing, it's a small world, gets smaller all the time, and our friends become colleagues and mentors, either from afar or adjacently, and I think those relationships are what make transplants so exciting and part of the reason that we have all of this innovation to talk about. I couldn't be more thrilled than to share with you some of the work that we've done. And while it sounds like a lot to Marwan's introduction, I promise it's all connected in a way that makes sense. And that connection revolves around our patients. It's the reason that we do what we do. I'm going to start and finish with that in mind. And if I had one goal today, it's to inspire each of you that if there's a way to help just one more patient, we ought to be trying to do it. And I think all of us at the, burning the midnight oil and staying up late, like last night, to do a liver transplant, that's very difficult to scale. It's difficult to do. And I think it's time that we think through the challenges that we have and look to technologies, systems, and operations and ask ourselves, how can we take what we already know and bring that to help more patients? And so that's the gist of today's talk. Now there's a mouse and 3 computers up here, but I think I can figure this out. I have disclosures. I have many. Most importantly, I am a super passionate transplant surgeon. I love what I do. It is absolutely fantastic to get to hold the hands of people that are receiving the gift of life and to be in the operating room teaching residents. That drives my interest in the rest of the things on this list. I get paid to do that. I think I'm supposed to say that. I get research funding, and I've started many companies, which is exciting. Happy to talk to you about them at a different time. Sue did make me fill out a disclosure form where I actually had to list all of that. And I work at MUSC on the venture fund there. Happy to talk more about that too as well. This is not a slide that's new to any of you. It's not been updated, but the lines all look the same today as they did in 2016. And that is to say that we have 110,000 people approximately listed for a transplant, but we only really do about 40,000 transplants a year. And a lot of those patients on the list don't get on the list until they're sick enough to get on the list and thus die before they ever get a chance to get a transplant. And while that 100,000 number sounds high, trust me, it's not even close. 300 million Americans, 350 million approximately. Of the 300 and of the, do we have a music?
Not just the babies.
Oh my gosh. Okay, great. Yeah, I was like, I don't think I put music in my slides, but with AI, who knows? Well, great. That's great about the baby. And it's timely given this light. So there are 300 million Americans. 15% of people have kidney disease. That's 45 million people affected by chronic kidney disease. And if only 5% of those go on to the point where they need a kidney transplant, it's not 100,000 listed, it's 2.5 million. Those are our patients. And when my head hits the pillow at night, it's not the 100,000 that concern me. It's the 2.5 million that are never even going to get a shake. And we need to think about how we can better access those patients and give them the therapy they need so that they certainly have a chance to experience those 4 reasons to live. And so what would it look like? By the way, I usually walk, but I'm told that I have to stay in this one little box. Nate's killing me, but I would be normally pointing very excitedly at the screen. Generally, when we have a great solution to a problem, it scales by some percentage over time, such that if you were to implement a new innovation, a new product, a new offering, you'd have some growth rate of 5 or 7 or 8 or 10% that looks a lot like the curves in the upper part of the screen. But that's actually not the case. Since we've implemented transplant as a solution, we've had almost linear growth when it should have been nonlinear. So since the implementation of the first successful kidney in 1954, and really since the early 1990s when we had, thank you very much, the early 1990s, when we had tacrolimus enter the space, we ended up with the curve on the bottom, largely linear, gentle year-over-year growth. Had we scaled using some of the innovative technologies that we now have at our graph, at a rate of 5 or 7%, we'd be doing more than 140,000 kidneys per year. And we would be starting to tap into that 2.5 million. That's the kind of thinking I believe that we need in the field. Let's bring this back down to sort of level ground. I started at the University of Maryland in 2016 running their pancreas transplant program, and we faced the curve on the right side of the screen. I was excited and fired up that I got to direct a program, but the reality is that pancreas transplant volumes have been decreasing across the country. And so, and this continues very sadly to today. We're only doing about 700 or 800 pancreas transplants nationwide every year. It's not a very big number. And so we're looking at this, asking ourselves, well, what are we supposed to do here? How am I supposed to grow this program when nationwide there's a reduction? What's going on? And so very organically, without any sort of leadership training, we gathered everybody in a room and we said, guys, this is a problem. We only have 10 patients listed. We only did 4 or 5 pancreas transplants last year. Do we even want to do this operation? And everybody said, oh, well, yeah, of course we want to do this operation. Right? Do we know how to do the operation? Yeah, well, of course we know how to do the operation. Well, we're not doing the operation. And this means people that are listed, either A, we're not listing people and giving them an opportunity, or B, we're listing them and not doing the transplants. And so we built a relatively homogeneous, very basic protocol to allow patients to get listed, largely using the kidney list. And we showed our team this data. We said, if you perform this transplant, you are more likely to be a kidney pancreas transplant. You are more likely to be alive than if you get a kidney and you have diabetes. And in that regard, we sort of broke down these silos. We started asking ourselves, I know what we normally do, but what if we just thought about this a little differently? What if we embedded a clinic, as an example, in the endocrinology clinic? Transplant surgeons would show up every Monday to the endocrine clinic where we had our own room. And do we get a lot of referrals that way? No. But you know what we did? We started building the culture that transplant was present. It was an option. And that level of excitement began to drive outcomes. And what we saw was that not only did we list a lot of patients, like you see on the left panel, but we actually started transplanting more patients. And with volume came standardization. Foreshadowing for the later portion of this talk, when we really start scaling access on the kidney side. And what we did was we not only increased volume, we really started reducing failure. We dropped our thrombosis rates to less than 2%, right? Length of stay began to drop, and we had very few technical errors, right? This is through basic protocolization. There's no magic wand. This is just devoted, hard work from teams that care. And we became the busiest center in the country. Very cool. As we did that, we encountered new problems, as always occurs, right? We build a new process. We're all excited about it. And then we begin unmasking stuff that we didn't even know was present. Specifically, the logistics of performing the transplant got in the way of actually performing the transplant. I'll never forget taking the call from the local organ bank. They said, we've got this pancreas and a kidney for you. He said, that sounds great. I'll take it. And he said, yeah, but you can't have it. And I said, but you just offered it to me. I said, well, the flight is going to delay it such that when it arrives, it's going to have too much cold ischemia time. And in that moment, it struck me that I don't think at any point the CEO of American Airlines or Southwest got a medical degree or had an intention of deciding who was going to live or die on the transplant list. But fundamentally, that's exactly what was happening. And unsustainably, we can't send a jet for $80,000 every time we're going to do a transplant, right? It would put everybody out of business. And so as the cold ischemia times started going up on these organs that we were accepting from further and further away, we realized that there was a real problem with moving organs. In the kidney space, as we adopted things like KAS, the new KAS and various concentric circles for where kidneys live and how they're going to come in, we've all experienced this not only on the pancreas side, but on the kidney side. And you begin to ask yourself, just like we faced in pancreas, do we really want to do this? Yes. Do we know how to do this? Okay, fine. Well, maybe we need to get out of our silo and start thinking about a different way to approach this problem that we've all looked at for a long time. The term innovation gets thrown around a lot. And frankly, the more I use it, the more I think I don't like it anymore. Innovation is something that we all ought to be doing. There are a lot of things that are new, but a lot of those things that are new are not necessarily novel. Those things that are new and novel, we call inventions. And inventions that are new and novel that actually allow you to either talk to new people, i.e. break into a new market, or do something perhaps safer and cheaper, right? Extending the reach. Those are innovations. Things that are operationally sustainable, right? I have a great new pair of tennis shoes that make me walk 0.1 mile an hour faster, and they cost $10 million. That is not innovative, right? That is novel and new. It might be an invention, but it's actually not sustainable. That is not innovative. And those things that then generate whole new opportunities to help new groups of people, those are formally disruptions. Well, as we break down the barriers and the silos that face the logistical challenges of transplant, this is the process that we were fighting with. Can this be innovated? Right? We have, God bless our OPO colleagues, 56 of them across the country, burning the midnight oil to try to find that liver for Nasser to put in the middle of the night, right? Organizing teams of couriers, and we've all been a part of the text message chains countlessly, right? Now being measured at more than 8 hours of communication required to do one kidney transplant, 8 hours of planning, right? Now that incorporates all the different stakeholders, but there's a lot of time and effort that goes into this. In order to find a doctor, to go to the hospital, take the organ out, to, put it in a box, take it to the tarmac, switch flights, and then eventually put it into a person. That was getting in the way of our own growth. Well, how do you break that down? Certainly going to be tough. And not only is it tough, it's expensive. The more that you move the organs, the more expensive that the process gets. And so we proposed this. I'm getting very excited, very excitable dude to begin with. I'm all fired up and I'm like, I got it. We're going to move organs by drone, right? And I got laughed out of a couple offices. But the idea being that this doctor on the left picks up their phone, they hit the easy button, the drone lands on the helipad, takes the organ, it lands at the other hospital. That ought to be what happens, right? We have this problem. Let's break down the silos. If this could work, man, we could really help a lot of people. Not only is it new, it's relatively inventive, right? It might be sustainable, and we might be able to actually help more patients breaking down those fundamental challenges that I shared with you in the beginning, getting closer to closing that gap of patients that need to be treated. So is this possible? Now, this drone is not the one that we used first. This is going to be part of our clinical trial that we begin in 2026, but it's really, really cool, so I wanted to put it on the slide. Huge technological advances had been made to that point, and it struck me that this might be a real opportunity to use new tech to change the way that we do transplant. So it's Friday afternoon, and I pick up the phone. It's 5 o'clock on a Friday, and I call coldly the Department of Aerospace Engineering at the University of Maryland. And this guy picks the phone and goes, "Hey, this is Norm." And I was like, "Great, Norm, this is Joe. I do transplants. I want to put organs on drones." And he goes, there was a long pause because I thought he was going to make fun of me too. And he goes, "I think that sounds great. Let's do it." And turned out that Norm was the chairman of the division. And as the only person that's going to answer the phone at 5 o'clock on a Friday, somebody that really, really cares, which began a long relationship that we continue today. He continues to be on all of our publications, and we're working together on next year's clinical trial. But this became a real option. Well, then we started socializing this around, right? Just like we got all those pancreas transplant stakeholders in a room and said, do we want to do this? Is this something we know how to do? This is going to require the same level of advocacy, but it's going to be a lot harder. So we started talking to folks in the Office of Technology Transfer. They told me it was crazy. It was impossible, right? Talk to the departments of surgery. It's too big. This is going to be, you're not even gonna be able to get your arms around the people that need to show up. And then eventually, I was actually in the Office of Technology Transfer with one of the lawyers. And they said, I'll never forget. I said, "This is what I want to do, and here's how I think it should look for the country." And she says, "It's never going to happen." And I said, "Oh, perfect. Yes, it is." And then she goes, and then she slammed her card down on the table and she slid it across. She said, "When it happens, you call me." And I was like, "No problem." She did come when we had the press release. But So, all these folks told us it was not going to be possible, largely because it had never been done before. And so we begged for money. Nobody would give me money to fly organs on drones, but they would give us money to build the technology that would allow us to talk to a drone when the organ was in the air. So I took all that money and I bought a drone, which is exactly what we're doing. Now, this is a funny story. I could talk about this for forever. This is the first day that we began testing drones for moving organs in 2018. And that is a Chinese-made drone called DJI. If anybody spends any time in the drone space, you can look it up. This is a thing. And it turned out that after we did this, and there was a little bit of press around it, the Federal Aviation Administration did not think it was very funny that we were actually flying Chinese-made drones with American organs and such. And so that was my first foray into, you think the IRB is bad? Welcome to the FAA, right? Like different level. So we began testing organs on drones and it looked like it was going to work. And then we flew our first organ safely in a controlled environment for research purposes in Southern Maryland. We began then testing what happens to an organ that's moved by drone. Is this worth doing? Is it any different than moving it by car, by airplane? And we began testing things that frankly had never been tested before. Are organs vibrated when they're moved? Does the pressure change? Do they get the bends? Does the biologic tissue moved actually have an outcome that's measurable? And it turns out that the answer is yes. In an Australian study, in current form, if you move a liver by air, the 1-year survival is in the 80s. If you move it by ground, it's in the 90s, consistently and statistically significant. There's something that happens when we move organs by air that we are not currently measuring, and we began to see that here. There are huge changes in vibration. And so although we tested this and we began to understand we can learn what happens to an organ moved by drone, not only that, we can actually do it. Could this be done in reality? And so we took then our science and we brought that to like the city of Baltimore, the state of Maryland, senators, congressmen, the FAA, and began having this what began a very long discussion about could this actually be done in clinical practice. We then got a series of new grants. The state of Maryland was very excited about this and funded it. We then built this drone, which is shown in Maryland colors. I hope you can all appreciate that. It was called Lewis Griffin. These are engineers. They get very excited about what they invent. And this was the first non-Chinese, formally first organ drone, which then subsequently we tested, got FAA approval for, and then on April 16th in 2019, we used it to move the first human organ. We then developed a far more sophisticated version of the tracking software such that we would know for the first time, because this organ was not going to be with a person at all. Right now, when you get a kidney or a liver shipped, it comes with a person. There's a human being with it at all times. Well, how do we know that at scale, the organ that just showed up is actually the organ that you put on the drone? I mean, if this thing went several hundred miles, it would have been completely absent of people. And so just understanding what organ is in which box and what's happening to it became important. So thinking with that in mind, understanding how organ tracking, frankly, wasn't even done when we started all of this, we built out some new software, which we then commercialized, and I'll talk more about that in just a minute. We then performed the first transplant in 2019. It was a kidney. It was only moved 3 miles, but it was assimilated seamlessly into the system such that it took off from the helipad of the organ bank and landed right on the roof at the hospital. We brought it downstairs and transplanted it at the University of Maryland in OR 21. It worked immediately. There were no changes in histology before or after drone flight, despite some of the challenges that I shared with, for example, things like vibration, which is something that we continue to discuss. That story, which was shared widely in the beyond the scientific press, touched lots and lots of people. It generated enormous media attention. And this really stuck with me for a couple of reasons. Number one, it was really, really cool to get to interact with all these folks, but people cared. Somehow people knew about the gap. We know that there's all these people to help. And if we can do stuff like this, holy smokes, we might be able to help treat those patients. The world cares about transplant. And so we said, well, if that's the case, the dean wants you to write a paper, we'll do that, and get a grant. Okay, fine, we'll do that. But if we limit our thinking to the science and the paper, we never actually help the patients that generate the closure of the gap. So I said, well, what do we do now? So somebody called me on the phone. I'll never forget. I was actually driving to my parents' house. They live in DC. And they said, oh my gosh, I saw this thing about the organs and the drones and all the tracking and all this different stuff. He says, I want to invest in your company. And I was like, oh man, that is awesome. What company? I was like, I'm a scientist. And then he sort of like, through the phone, sort of shook my shoulders and was like, no, 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 no. This doesn't stop here. In order to help the patients, we need to have an offering. To have an offering, we have to operationalize this. To operationalize this, we need to make a company. And so it was in 2018. I was very fortunate to work with one of the founders of Under Armour, who was a logistics expert, right? Moving things all across the world, to fund what became Medigo, the first organ tracking system for transplant networks, which was operationalized to 45% national market share and purchased by CareDx, which is traded on NASDAQ. We had about 25 employees at the time of the acquisition, and now every organ in the United States is tracked with that technology or a similar technology. And we're very proud of what that work was. Now, we were about 10 years early on drones at that time. We did stand up a company that secured some, $50 million contracts for some work that was outside of the transplant space, but that work continues, and we'll certainly, you'll hear more about that in 2026, which is exciting. After some of this, we said, okay, fine. So we did all this work. Do people care? Is this something that we really need to run down? We did a survey of 145 transplant surgeons, and 87% said that the work that we do in transplant is inadequate from the standpoint of logistics and communication. We don't have enough infrastructure, and we need it. And so you wonder how you're going to help all those patients to break that gap down. This is one place to start. Some of that early work that we did, again, showed us differences in pressure, temperature, and certainly vibration, work that continues now. And that work was really the foundational work that led to not only our first company, but some of our key learnings that are going to fuel our clinical trial. Now, I'm just going to spend I used to have 10 slides on COVID because I was always giving this talk during COVID on Zoom. But there are off-target benefits of innovation, right? Not only is this a seamless way to move organs, but it's also touchless. It's easier, it's simpler, right? And fundamentally, it will be cheaper. We like every good scientist, we took these learnings from our initial experience moving moving organs by drone, and we took it back to the lab. We said, we're starting Medigo, we're tracking organs, and we're starting to see that these organs do experience differences in their environment when they're moved. They're real. And if that's real, should we do something about that? Because if we can change that, we can not only improve the logistics, we can even improve the quality. So we built a small animal model. This is a heterotopic heart transplant. What I just showed you is a beating heart in the abdomen of a mouse. And we began vibrating those organs at the level, like I shared with you in the liver transplant study from Australia, at the level consistent with an airplane. And what we found is not only did those organs that were vibrated fail, but they didn't fail right away. It's not like we destroyed the heart. What happened is that they all failed at about 3 weeks from an accelerated rejection-like mechanism, probably indicating that whatever it is that we're doing probably is not safe for some of the tissue that we in fact move. The hearts still work? Yeah, they do. And we overcome it, right? And we treat those patients, but something is happening. We then asked ourselves, what does that really look like? It turned out to be largely apoptotic driven. And then what we started doing is treating those hearts in the mice that are vibrated with anti-apoptotic agents in order to see if we could undo the damage that we had just generated. And it turns out that you can. So there is a very clear mechanistic and biologic effect occurring as a result of just the way that we're moving organs, further sort of making the case that not only do these organs need to be moved more safely, they need to be tracked, and we really need to understand what's going on with them. So where does all that work stand today? This again is doing science, actually implementing it, learning from it, standing up a company, and then taking those additional learnings back to the laboratory. We said, all right, fine. We think we now understand not only how to, if we can move organs by drone, and we think we should move organs by drone because we don't think we're harming them, right? If we were going to do that, could we test this at a distance that was relevant? We only did this for 3 miles. So we set up a new drone program. This is one that we completed last year as a part of an NIH-funded trial. And we moved a simulated organ, so not actual organs. We didn't need to use human tissue in this context. 100 miles using some very fancy technology that would be required if we were going to do this for 90, 100, 200, 300 miles. If you were really going to do this, do the technologies exist and can they be implemented? So what you see here is a series of very cool technologies that include real-time organ, three-dimensional organ mapping. That's what you see in the upper left. So if there's another plane, how do you dodge the plane that the organ drone is facing, right? There's no person on the drone. So we were able to do that. We have a series of almost daisy-chained, really high-end sonar devices like you see on the right. And then you can see the drone technology continues to improve, which is what you see in the bottom left. This is our test team here. And this is it. So we completed 100 miles of drone flight less than a year ago. And so that should be coming out in AJT over the course of the next 2 or 3 months. Pretty exciting development. And what we learned there, we compared 100 miles of drone with 100 miles of car and 100 miles of airplane. Like, if you're really going to do this and do this in a way that matters, how does that actually impact the organ? And should we be building and testing new technologies that facilitate? What you see on the right is this is tens of thousands of data points reduced down to just several hundred. The maroon lines, or the orange lines, represent the vibration in G-force experienced by an organ when it's shipped by an airplane. So 5 Gs of force are impacting the biology of that organ when it takes off and lands, as well as some jostling along the way. Cars actually have the most variability in their impact on organs. And the drones are right down here, all of these green lines, right? Almost none. And it probably has to do with the amplitude of vibration that comes from an electric motor versus a high amplitude, low frequency gas engine. I'm not an engineer, but this is what they tell me. It'll be in the paper, I promise. And so what we found there is, not only can we do this, is it safe for the organ? And if we use organ drones, are they at least as good, if not better, than what we currently do? We thought the answer was yes. And so we then built an alliance of MIT from Boston, MUSC, and then about 4 or 5 best-in-class technology companies to stand up the first clinical trial, which we hope to begin in 2026. We'll be using this super fancy drone called the Cobalt. We now use AI-informed, real-time flight path coordination technology, which is what you see on the right. So we can have this drone fly autonomously, no person, over areas that have limited population, using AI to inform it based on not only traffic, but weather and all sorts of things. And so in Charleston, which is, I promise, what that map shows, we're going to be able to fly largely along waterways and avoid the organ ever traveling over people. We're going to be doing 150 of these over the course of the next 2 years, so more to come on the data there. Why would we do this? Doesn't seem like a heavy lift. We're talking about 40,000 organs a year. Well, my goal is that it's 140,000, like I showed you in that first slide, because that's where we ought to be thinking. It's the patient, the one who doesn't have a shot. That's why we're doing all this. And how does what we're doing today get us there? Well, in the current model, every time we do a transplant, one person has to travel with one organ. If we want to set up a program that allows us to do 600 or 700 kidneys a year at MUSC, I'm going to have to hire a courier for every single one of those organs. Unless you had a small team of people overseeing a huge number of autonomous technologies that could seamlessly move these technologies for you. So the option, the exciting element here is that you can scale with what we already have, scale better access, more organs to help more patients. And that one-to-one versus one-to-many hypothesis is what we're going to be testing in the clinical trial. Now, all this stuff sounds great. We are working hard to actually bring it into the world. How is that actually going to change the landscape of ESRD? In a systems dynamics model, and Marwan, this is one of the slides that I was talking about sharing with you when we were at dinner last night. the total number of people in the United States expected to get kidney disease is going to go up. And it's going up faster than we can treat it, which means that the costs are going to balloon, right? I mean, this is relatively, this is pretty simple math. Now, if we could eke away with that, with policy change, with transmedics, with organox pumps, right? With oxygenated kidney pumps that extend cold ischemia time to improve the timing of surgery. And we have higher throughput models, which I'll share with you in just 1 minute. At hospitals, we could probably double the number of kidney transplants in this country using deceased donors, just the way that we have it. But we know that that's not enough. And eGenesis knows that too, as does United Therapeutics. And so as xenotransplantation takes hold over the course of really 2027, we think is probably when the floodgates are going to begin to open, and kicks up over the next 15 years, the total number of transplants that we're going to perform is going to go very, very high. So we all think we're busy now. Hopefully we'll have technologies like scalable drone tech that allow us to make it a little bit easier, but it's pretty easy. So where are we today? If we go back to the first slide, we've got this big gap. We never scaled. We never saw the 5 or 7% year over year increase. We didn't treat it like a real innovation. Is that because we've been doing a terrible job? Well, maybe, or maybe it's something else. This is what we call the curve of innovation, or the diffusion of innovation. If anybody's ever read Clayton Christensen's The Innovator's Dilemma, very famous book, I certainly encourage you to read it. He talks a lot about this. Again, Nate, I'd usually be at the board, but I'm not allowed to move, so I'm going to do my best to do it from the cursor here. When a technology is introduced, the innovators are the folks way down here, the 2.5% that are learning how to do things and learning how to do them well and coming up with new ideas, like all your transplant surgeons, faculty, and researchers. You'll then have people that actually start using that technology, right? And then that technology, that's usually the point where you have this huge inflection point where you have rapid growth, and then eventually sort of the entire market comes on board, such that over here you've got penetrance of the market up near where it needs to be close to 100%. Well, one argument is that if transplant itself is the innovation, not these individual things, but the whole field, maybe part of the reason that we're linear is because we're actually right here. We've been innovating and trying to figure it out, but we haven't been able to scale. But now we can. Now we have transmedics, we have organox, we have pig kidneys, we have drones, right? We have quality metrics and understanding. We are very likely, I am excited to share, about to hit the inflection point. We figured out how to do transplant, and we are about to go from linear to nonlinear. That is one interpretation. And it's exciting to think about that, because without that, there's no other way to get to that 2.5 million people that need their lives saved. What would this really look like? Well, if you look at the scale on the graph that I've got here on the bottom, and I'm just wrapping up, I just have a couple more. You'll see that goes up to 2080. Okay. So as these technologies come on board, is it possible to actually change the incidence of kidney disease and the penetrance of kidney disease in the United States? The answer is yes. What is it going to take? It's going to take 65 years, but it can happen. And it starts today with thinking out of the box, with challenging yourself and your teams. We've started that at MUSC. This incredibly complicated graph looks just like yours. It just says it's really hard to get patients to move through the system. It's tough, right? There are lots of coordinators, there are referrals, they come from different places. We have fax machines, for God's sakes, still, right? And trying to disentangle this to try to make it, to get more patients through the system is tough. And so understanding that big inflection point is coming, innovation is here, we need to embrace it, forces us operationally to say, okay, how can I absorb another 300 kidneys a year at an MUSC? So at MUSC, we did some math and started asking ourselves, could we build an operational model that would facilitate growth to 1,000 organs? Because that's the number that we need to hit based on the need, right? And we think we can actually get there. Well, if that's the case, we can't go to the operating room and say, hi, I have 12 kidneys to do today. The Tetris doesn't allow us to do that, right? So there's got to be a better way. Part of that is rethinking transplant. It is a reactive field like trauma, not a proactive field or a scheduled or elective field, right? We're like endocrine, where we may know that we have a surgery 3 weeks from now. Right? We don't find out until 12 hours before the case. But we can model it. And if we can model it and we know that we're going to do 2 or 3 kidneys in a day, and we can prolong the cold ischemia time safely on a pump, which we now have, and we can optimize the logistics and know when the organ's going to arrive, which we can now do, we can then plan for the health system to absorb the volume. And that's exactly what we did. We built what's called the semi-elective transplant initiative by teaching the OR that we are statistically likely to accept a certain number of organs and that we will take risk on cold ischemia time if you can offset that risk through operational excellence in an operating room. And by doing that, we've effectively eliminated nighttime surgery. It's going to generate $140 million of new revenue, which is, by the way, this is the reason the CEO signs off on things, right? And it has a high net present value. What does that really look like? Well, right now, surgeons sort of get you from A to C, right? We can only do so many surgeries banging our head against the wall with the resources that we are given. But what if you scaled the surgeon? What if you took away all of their headwinds so that they could absorb and do more cases? So we generally have a kidney transplant down to about 60 minutes in our operating room. And we do first case start every day. It's room 11, starts at 8. The second case is at noon. And if there's a third kidney, it starts at 4. Nothing overnight. We've reduced our length of stay, right? Usually it's 3. We're at about 2.5. Frequently have 2-day discharges, lower blood loss, and great surgical outcomes. And part of that is because the same team is there every day at the same time, doing the same work, and it's driving a positive change in culture. We went from unnamed caps in the operating room to now everybody has a transplant cap. Everybody wants to be on the transplant team. It's super fun. We start at 8, they're done at 4, we save a bunch of lives, and we turn up the music real loud. Hold on a second. There we go. This is an executive summary of what we've done. It's exciting. Is there data to support this? Absolutely. This is a super busy slide. Sorry, it's part of our abstract for ASTS winter. So please come, we'll share more. If you look at the total number of organs that we've done with 30-hour or more cold ischemia time, keeping in mind there's been no difference in not only DGF rate, but organ survival at 30 days and 180 days. We have taken our 30-hour kidneys, accepted kidneys, from 0.5% to 7.7% of our total kidneys that we transplant. We got rid of the headwind. Those are the organs that the surgeons used to say no to because they never knew when they were going to go in. And by eliminating that concern, we risk mitigated around the logistics and we were able to get those organs transplanted. So in wrapping up, thinking like this allows us to hit the inflection point. The inflection point allows us to tackle the 2 million people who need our help. And those 2 million people matter, and they matter a lot to CMS, like $100 billion a lot. This is work that needs to get done. But unless you take the ideas, the solutions to the problems that you see every day beyond the 4 walls of your hospital, it's not going to happen. If we stop at the paper and we don't start the company, the patients don't get the benefit, right? If we have the idea, but we don't write it down and we don't socialize it and take risk on being made fun of and thrown out of some offices, it's not going to happen. But taking some basic ideas like this, can I do a kidney transplant faster, safer, cheaper, is going to allow us to do 4,000 additional kidney transplants in the United States based on just some basic operational changes alone. And there are more patients to help after that. I'm going to end here. I did get a TED Talk recently, and it was really about my experience talking to patients before we go to the operating room. We hold their hands, and these patients who maybe have never seen us before because they were evaluated 5 years ago, see a couple of people show up in pajamas and say, by the way, you might die. We're going to give you this organ that comes from another person who died. Like, that's what they're going through. And we do that 3 times a day, but for them, it's once in a life. What's in a lifetime? And I ask all of them, why do we do this? And they do share their reasons. And please go watch the talk. But they want to get a transplant because they want to live. They have goals. And that's why we're here. It's not to sew in the organs and hit the 100 billion. That's a representative of the size of the problem. But we're here to get people to weddings, We're here to get people to watch their kids walk down the aisle or graduate from school. And there are 2 million of those people who need our help. These are the people who have helped me. My postdocs along the top there, some reasonably well-known OPO leaders around the country, in addition to some CEOs and some other folks that you may recognize. Indebted to all the institutions that have supported some of these wacky ideas along the way, gone to bat with me for the FAA and the IRB and some other folks, because without them, none of it would have happened. And with that, I'll say thank you for sharing this time with me. And for God's sakes, if you take nothing else away, try to take the ideas that you have and extend them beyond the 4 walls of your institution, because unless we do, nobody's going to get helped. Thank you very much for the time. What's the question was? I'm supposed to repeat the question, I'm told. Okay. See, and I can be taught. The weight limit on the drone is a great question. So, I shared earlier, we were about 10 years too early when we first started this program, because I was super naive, which is a great thing to be when you're doing big, bold stuff. If you know all the problems, you probably won't do it. The Federal Aviation Administration limited shipment of, including the weight of the drone itself, to 55 pounds under what's called Part 107. You don't have to remember any of that. But federally, you weren't allowed to have a drone plus its payload go above a certain point. And that actually really negatively impacted the ability to have any true civilian use. None of that stuff applies for the government, of course. They can do whatever they want. And so we had to keep everything below a total weight of 55 pounds, which was a critical discussion with the FAA. And we were also limited to only 3 miles. I mentioned 10 years ahead because we were waiting for Part 108. Well, Part 108 was just passed. Now there is no longer a limit on the weight, and the distance has also been lifted too. So now you can go what's called beyond visual line of sight. So the need for the technologies to track and all this different stuff were all required to get where we are today. And now that we have them, now we can go the far distances, which is how we're going to do the clinical trial. In that regard, all you need is a drone that can lift more. To be clear, I mean, I came here on like a 757 or something like that, and that flies almost autonomously the entire way. There's a pilot in the front seat, but fundamentally the plane is flying itself. And so the technology that one chooses to use is simply based on one's investment in that particular problem. The ones that we're going to use here for the clinical trial go about 100 miles an hour. They can carry payloads that the payload can exceed, it can go to about 20 or 25 pounds. For the physics nerds in the room, the temperature of the air, the battery power, the amount of payload, the distance and some of the environmental factors change how far it can go and how fast it can go. Faster you go, the more battery you drain, the colder it is, the less the battery holds a charge, and all these different parts of the puzzle that we have to solve for. And that's part of the reason to do the trial too, to see what is the likelihood of actual success in a last mile drone delivery. And so the ones that we're going to be using have a payload of about 30 pounds roughly. We're going to put on it about 15 to 20, and they're going to about 100 miles an hour. Yeah, they're going to be shipped in cold storage, but the design and the thinking, again, think with the N9, is to put them on the equivalent of like the ORS kidney perfusion pumps. Yeah, so there are a couple of companies, they're in my disclosures, for sure, that are working on drones that have either a fuselage large enough to just take a standard pump. That's probably the right answer from a business standpoint. There are a couple of other companies which I help them, but that are trying to kind of do everything. We're gonna make a pump, and by the way, we're gonna keep it cold, and we're gonna make a drone, and we're gonna that usually doesn't work out. It also doesn't work out when you have to change practice. So the notion that you would have a drone that was the pump, as an example, you'd have to teach people like in service that are like at an OPO, how to work with a drone, right? That's very difficult. So we're very likely going to have larger fuselage, larger weight load or payload drones, and then they can use different, for different use cases. Yeah. I mean, there are current military drones that are deployed already in the Ukraine that carry people. So, I mean, it's just a tech question. They can build anything. I actually took this to MIT and I was like, I need a drone that goes 100 miles an hour and carries like 50 pounds. And I was like, can it be done? They're like, I mean, like today? Like, I mean, yeah, sure. Just a plane, it's just a plane with some fancy AI. So yeah, it's exciting stuff.
So Joe, one of the companies that does the porcine xenos show that one of the meetings that own drones.
Yeah.
They're pretty substantial, and they mentioned that they can go on a single charge across from Virginia to Seattle. Any thoughts on those drones, or how do they fit in the paradigm of the drone for organs?
Yeah, I think that CEO is featured on the prior slide. The ideal scenario is the first hypothesis slide, where one of us providers picks up the phone, you hit the easy button, the drone lands, and then it flies 600 miles to its location. That's where you want it. That's our North Star. It's a little ways away. That's tough. Even those companies standing those drones up know it's tough. Just charging those drones to be able to go that distance securely and safely itself is that's a whole nother level of technology. So I suspect it's going to happen in phases. I absolutely think the companies that, the ideas I'm sharing here are kind of 2, 3, 4 years out, but there are companies, as they should, that are really thinking a decade out, that are really saying, I'm going to go to Washington State, right? And I know how to get there. It's a technological map, it's a roadmap, and it's funding and all that stuff. And those companies have certainly the funding and the staff to build it. I imagine we will have, if I were to guess, what if it amounts to a single OPO, we'll have a series of qualified and vetted courier systems, many of which use long distance medical grade drones that work on electricity and not gas. That is what I think is going to happen. It's what I hear kind of as I piece together all the different discussions. That's what it looks like. And I would suspect that individual companies who own their own pigs are going to probably have a vested interest in the technology that moves the organs that they build.
Yeah. You talk a lot about technology and innovation, but there's also the human innovation, which I think is really what's holding a lot of programs back, which is that people, whether it's the coordinators or the surgeons or the nephrologists or whoever, don't feel that they can do 600 transplants per year at the program because they don't have 600 patients, either because of the throughput or because their patients are just sicker than everyone else's patients, which isn't true, but that's the bias a lot of programs have. That, you have a patient who's been 68 years old, he gets 35%, that patient can't be transplanted. But that patient is, going out shopping, doing grocery shopping, and things like that. So how do you sort of overcome that bias?
Yeah, so this SETI concept, which is a semi-elective model, fundamentally, we named it SETI because I thought it was cute that this is the Center for Extraterrestrial Intelligence is also SETI, so this is why we named it SETI. But it's just really operationalizing different technologies and bringing them all together, where we have a more streamlined clinic that is pure human effort in the clinic to try to get it organized, right? We all do that already. In-house pumping, dedicated OR staff, right? And then very, very hyper protocolized education and discharge criteria. That's kind of what the model is. But the fundamental goal is to take down the headwind. Because in our old model, like that, I was showing you the triangle, surgeons no programs really do more than 300, and they kind of all stop there. And that curve, those always stuck with me. Are you doing 300 or not? It's kind of the question. Because everyone stops at that number. Like, why? And it's hard. you're banging your head against the OR front desk. Like, can I get a room? Can I get a room? Can I get a room? Well, the kidney's more important than the burn. Is the burn more important than the kidney? Is the tumor more important? Like, if we're committed to the idea of helping these patients, it ought to never be a question that you're going to do this case at the time that makes most sense for the patient. It's not about convenience for me. It's not about convenience for the anesthesiologist. And so I think if you get rid of all the headwinds, the human element comes with it. The culture improves. It's fun. It's easy, right? Not the transplant. That's never easy. But the process of trying to help this person ought to be easier than it is today. And I don't know that the SETI model is easily replicable elsewhere, because I do think the headwinds that exist are slightly different at each individual program. But I do think you can eliminate them. And I'm telling you that if you eliminate them, your surgeons are going to say yes, because everybody wants to help the patients in the way that makes the most sense. And that's been my experience. So I think the tech part is important, because without it, you can't help the patients, but you still have to do the work. And then figure out how you can lead through the implementation of this stuff in order to help as many patients as you can. I think it's hard. I think it's hard.
So my question is our thinking. Transplant, CKD, dialysis and transplant is reactive. We have not been proactive. Have you thought about getting out of that box and thinking proactively, the 37 million people who are at risk, what are we going to do with them? How are we going to take care of them? And should there be higher insurance, something to change human behavior? Starting with high school or maybe even middle school, start teaching people about health. Now that would be thinking outside the box, because if you don't take care of your health, you're going to be paying higher premiums. There should be something along the lines. You have to think out of the box.
Yeah.
In order to prevent that from happening.
So you're exactly right. So the only way, now I can move. So the only way, like part of the problem is you still have to get over the hump. All the people that are going to have kidney disease diagnosed in the next 5 or 10 years, it's already been done. Damage is there. It's going to happen. So those people are going to need transplant. Like, even if we ramp up a GLP-1 to everybody and somehow eliminate diabetes, it doesn't change the fact that people for the last 25 years have had diabetes and are all going to get killed. So there's a huge, element of this that you have to get over, right? That is the prevalence. And then there's the incidence, which is where you're talking. To get down here and stay down here, there have to be preventive measures in order to make sure that the diabetes doesn't occur, or that the hypertension is treated. In the immediate term, so I completely agree with you. And I think that the really exciting innovations that are going to drive this are in process. Longevity, we've all heard the term now. This is where we're going, is the idea that no one gets sick because you're monitoring your blood work every month or twice a day or whatever the crazy new trend is. And we're all taking NAD+ to improve our mitochondria or whatever. But that's got to happen. In the near term, there are people that we don't list until they're already on dialysis for years. If I were to change the policy, which I'm not here to do, but where we can advocate and go beyond your four walls, is that the minute your GFR is like less than 30 or whatever, and you have a source, you have a driver of kidney disease, why are those people not getting listed so that they never have to go on dialysis? Now, there's an alignment around finances and insurance and the way that we pay for things that's probably going to get in the way of that vision. But I agree with you. And fundamentally, I think that there are a lot of opportunities to improve it. And I think preemptive transplants and I think early listing and avoidance of dialysis allows you to never get to the EF of 35, right? You don't let them get sick enough.
Did anywhere along the line anyone think about a vacuum capsule to prevent any vibration injury?
We have the engineers have built into the drones some sort of vibration absorption technologies. But what we've learned is that it's probably the plane, the helicopter, and the car itself that exposed the organs. The drones don't seem to they have almost no vibratory effect on the organs being shipped. So for this model, we don't need very much. In the current traditional model, we probably ought to have better tech that exists in that space.
Would be potholes in Detroit.
Yeah.
Well, thank you so much.
Yeah. Thank you guys. Appreciate it. Yeah, thank you. Thank you.